Hello ladies and gentlemen, first of all let me thank you for subscribing to my channel. In today's lesson, I will talk about acute hepatic failure in children. Acute liver failure is a clinical syndrome which results from massive necrosis of hepatocytes or from severe functional impairment of hepatocytes. The synthetic, excretory and detoxifying function of the liver are all severely impaired in acute liver failure. Since hepatic encephalopathy can be difficult to detect earlier in infants and children, and also since some children in acute liver failure may not develop encephalopathy, we do not wait for the presence of hepatic encephalopathy to diagnose acute liver failure in children, unlike that of adults. So, the accepted definition in children to diagnose acute liver failure include biochemical evidence of acute liver injury, which is less than 2 months, no evidence of chronic liver disease, and hepatic-based coagulopathy, which is defined as a PT greater than 50 seconds or INR greater than 1.5, which is not corrected by vitamin K in the presence of clinical hepatic encephalopathy, or prothrombin time greater than 20 seconds or INR greater than 2, regardless of the presence of clinical hepatic encephalopathy. When we came to the etiology of acute liver failure in children, the first and the most common is infection. Acute hepatic failure can be a complication of viral hepatitis A, B, D, and sometimes E, and also other viral causes such as Epstein-Barr virus, herpes simplex virus, cytomegalovirus, herpes type 6, and varicella zoster virus, adenovirus, enterovirus, influenza, and parvovirus, and also other respiratory illnesses. An unusual high rate of fulminant hepatic failure occurs in those who have combined infection with hepatitis B virus and hepatitis D virus. Hepatitis B virus is also responsible for some cases of fulminant liver failure in the absence of serologic markers of hepatitis B infection. But even if hepatitis B surface antigen is negative, there is hepatitis B virus DNA found in the liver. The other is autoimmune hepatitis. Acute hepatic failure is caused by autoimmune hepatitis in approximately 5% of cases. Patients have a positive autoimmune marker and possibly an elevated serum immunoglobulin G level. On biopsy, in the case of autoimmune hepatitis, liver histology often demonstrates interface hepatitis and a plasma cell infiltrate. The other is metabolic disease. Metabolic disease as a cause of acute liver failure are suspected when there are multi-organ involvement and more than one members of the family are affected. In addition, metabolic disease as a cause of acute liver failure are suspected if there is other clinical conditions such as interactable vomiting, failure to thrive, interactable hiccups, hypoglycemia, and coma at presentation. It suggests metabolic cause of acute liver failure. Metabolic disorders associated with hepatic failure include Wilson's disease, acute fatty liver or pregnancy, galactosemia, hereditary tyrosinemia, hereditary fructose intolerance, defects in beta oxidation of fatty acids, and deficiency of mitochondrial electron transport, and others. The other cause of acute liver failure include neoplasms. Acute liver failure can occur with malignancies such as leukemia, lymphoma, and familial hemophagocytic lymphohistiocytosis. Acute liver failure is a common feature of hemophagocytic lymphohistiocytosis, which is caused by several gene defects, infections by mostly virus of herpes group, and a variety of other conditions. Patients with HLH present with a combination of fever, splenomegaly, cytopenias, high triglyceride levels, very high ferritin level, and they may also have hemophagocytosis on bone marrow or liver biopsy. The others are drug-induced liver injury. Various hepatotoxic drugs and chemicals can also cause drug-induced liver injury and acute hepatic failure. There are predictable and idiosyncratic damage. Predictable liver injury can occur after exposure to carbon tetrachloride, Amanita phyloides mushrooms, or after acetaminophen overdose, whereas idiosyncratic damage can follow the use of drugs such as halothane, isoniazid, and also anticonvulsants such as sodium valproate. Herbal and weight loss supplements are additional cause of hepatic failure, mainly in different areas of the world, such as herbal cause is common in where traditional medicines are used for treatment, and the weight loss supplement is those who is given for obese peoples. The other is vascular ischemia and hypoxia resulting from hepatic vascular occlusion, severe heart failure, cyanotic congenital arteries, or circulatory shock can produce liver failure. The others are idiopathic acute liver failure. Idiopathic acute liver failure accounts for 40 to 50% of acute hepatic failure cases in children. The disease occurs sporadically and usually without the risk factors for common cause of viral hepatitis. It is likely that the etiology of these cases is heterogeneous, including unidentified or variant viruses, excessive immune activation, or undiagnosed genetic or metabolic disorders. The pathology in acute liver failure, liver biopsy usually reveals patchy or confluent massive necrosis of hepatocytes. Multilobular or bridging necrosis can be associated with collapse of the reticulum framework of the liver, and there might be little or no regeneration of hepatocytes on pathology. The mechanisms that lead to acute hepatic failure are poorly understood, and only approximately 1 to 2% of patients with viral hepatitis experience liver failure. And why only 1 to 2% of patients with viral hepatitis experience liver failure is also not clear. Massive destruction of hepatocytes might represent both a direct cytotoxic effect of the virus and an immune response to the viral antigen. Of patients with hepatitis B virus-induced liver injury, majority become negative for serum hepatitis B surface antigen within few days of presentation and often have no detectable hepatitis B virus antigen or hepatitis B virus DNA in the serum. These findings suggest a hyperimmune response to the virus that underlies the massive liver necrosis in the case of hepatitis B virus-induced acute liver failure. Acute hepatic failure can follow depletion of intracellular substrates involved in detoxification, particularly glutathione in the case of drugs such as acetaminophen and isoniazid-induced acute liver failure. Whatever the initial cause of hepatocyte injury, various factors can contribute to the pathogenesis of liver failure. This includes impaired hepatocyte regeneration, altered parenchymal perfusion, endotoxemia, and decreased hepatic reticuloendothelial function. When we see the clinical manifestation, acute liver failure can be the presenting feature of liver disease, or it can complicate previously known liver disease, that is acute or chronic liver failure. A child with acute liver failure has usually been previously healthy and most often has no risk factors for liver disease such as exposure to toxins or blood product transfusion. Progressive jaundice, fetor hepaticus, fever, anorexia, vomiting, and abdominal pain are common. A rapid decrease in liver size without clinical improvement is an ominous sign, and hemorrhagic diathesis and ascites can also develop. Patients should be closely observed for hepatic encephalopathy, which is initially characterized by minor disturbance of consciousness or motor function. Irritability, poor feeding, and change in sleep rhythm might be the only finding in infants, and asterixis might be demonstrated in older children with hepatic encephalopathy. Patients are often somnolent, confused, or combative on arousal and can eventually become responsive only to painful stimulus. Patients can rapidly progress to deeper stages of coma, in which extensor responses and the decerebrate and the decorticate posturing appear. Respiratory insufficiency are usually observed in the last stage of problem. The respiratory failure can occur in the stage 4 coma. The pathogenesis of hepatic encephalopathy is likely related to increased serum levels of ammonia and also false neurotransmitters, amines, increased GABA receptor activity, or increased circulating levels of endogenous benzodiazepine-like compounds. Decreased hepatic clearance of these substances can produce marked central nervous system dysfunction. The mechanisms responsible for cerebral edema and intracranial hypertension in acute liver failure suggests both cytotoxic and vasogenic injury. There is increasing evidence for an inflammatory response which acts in synergy with hyperammonemia to cause severe astrocyte swelling or brain edema. There are a staging system for hepatic encephalopathy based on symptoms, signs, and electroencephalogram. In stage 1, based on symptoms, there are periods of lethargy, euphoria, and also only reversal of day-night sleeping, otherwise alert, up to stage 4, which is deep coma. And based on science, on stage 1, there might be trouble drawing figures and performing mental tasks, to stage 4, which is areflexic or asterexis flaccidity. When we see the laboratory findings in acute liver failure, serum direct and indirect bilirubin levels and aminotransferase activities might be markedly elevated. Serum aminotransferase activities do not correlate well with the severity of the illness and can decrease as a patient deteriorates. The blood ammonia concentration is usually increased, and as we have said, PT and INR are prolonged, and they are used to define acute liver failure in children. And this elevation in PT and INR they do not improve after administration of vitamin K. Hypoglycemia can occur, particularly in infants also. And hypokalemia, hyponatremia, metabolic acidosis, or respiratory alkalosis can also develop later during the course of the illness. Regarding treatment, specific therapies for identifiable cause of acute liver failure include N-acetylcysteine for acetaminophen, acyclovir for herpes simplex virus, penicillin for amanita mushrooms, and nucleotide analogs such as entecavir if there is a hepatitis B virus as a cause of acute liver failure, and steroids for autoimmune hepatitis. Management of other types of acute liver failure is supportive, and no therapy is known to reverse hepatocyte injury or to promote hepatic regeneration. An infant or a child with acute hepatic failure should be cared for treatment in ICU. Endotracheal intubation might be required to prevent aspiration, to reduce cerebral edema by hyperventilation, and to facilitate pulmonary toilet. Mechanical ventilation and supplemental oxygen are often necessary in advanced coma. Sedatives should be avoided unless needed in the intubated patient because these agents can aggravate or precipitate encephalopathy. Opioids might be better tolerated than benzodiazepine if they are intubated and the patient needs sedation. Prophylactic use of proton pump inhibitors should be considered because of the high risk of gastrointestinal bleeding. Hypovolemia should be avoided and treated with infusion of isotonic fluids and blood products. Renal dysfunction can result from dehydration, acute tubular necrosis, or functional renal failure, that is hepatorenal syndrome. Electrolyte and the glucose solution should be administered intravenously to maintain urine output, to correct or prevent hypoglycemia, and to maintain normal serum potassium concentration. Parenteral supplementation with calcium, phosphorus, and magnesium might also be required. Hypophosphatemia, probably a reflection of liver regeneration, and early phosphorus administration are associated with a better prognosis in acute liver failure, whereas hyperphosphatemia predicts a failure of spontaneous recovery. Coagulopathy should be treated with parenteral administration of vitamin K, and most of the time the coagulopathy in the acute liver failure is not corrected by vitamin K, and we should have to give fresh frozen plasma, cryoprecipitate, platelets, and activator factor 7 or prothrombin complex concentrates, which can be used to treat clinically significant bleeding. Patients should be monitored closely for infection, including sepsis, pneumonia, peritonitis, and urinary tract infections. At least 50% of patients experience serious infection. Gram-positive organisms are the most common pathogens, but gram-negative and other fungal infection can also be. Gastrointestinal hemorrhage, infection, constipation, sedatives, electrolyte imbalance, hypovolemia can all precipitate encephalopathy and should be identified and corrected. Protein intake should be initially restricted or eliminated depending on the degree of encephalopathy. If encephalopathy or hyperammonemia develops, lactulose can be administered. Cerebral edema is an extremely serious complication of hepatic encephalopathy that responds poorly to measures such as steroid administration and osmotic diuresis. Monitoring intracranial pressure can be useful in preventing severe cerebral edema before it happens, in maintaining cerebral perfusion pressure, and in establishing the suitability of a patient for transplantation. Liver transplantation can be life-saving in patients with advanced stage such as stage 3 and stage 4 of hepatic coma. When we see the prognosis of acute liver failure, children with acute hepatic failure fare better than adults. And the prognosis varies considerably with the cause of liver failure and the stages of hepatic encephalopathy. Survival rates with supportive care might be as high as 90% in acetaminophen overdose and with fulminant hepatitis A. By contrast, spontaneous recovery can be expected in only approximately 40% of patients with liver failure caused by the idiopathic or indeterminate form of acute liver failure or an acute onset of Wilson's disease. Prognosis is poor for spontaneous recovery in patients with mitochondrial deficits, hemophagocytic syndromes, herpes simplex disease, and idiosyncratic drug reaction. In patients who progress to stage 4 coma, the prognosis is extremely poor. Brainstem herniation is the most common cause of death in patients with acute liver failure most of the time. Major complications such as sepsis, severe hemorrhage, or renal failure increases the mortality. The prognosis is particularly poor in patients with liver necrosis and multi-organ failure. Age less than 1 year, stage 4 encephalopathy, INR greater than 4 or prothrombin time greater than 90 seconds, and the need for dialysis before transplantation are associated with increased mortality. A plasma ammonia concentration greater than 200 is associated with a 5-fold increased risk of death. This is all about acute liver failure in children. Thank you for watching.